Hi everyone, thanks for listening to all my presentations. Today I will be going through screening and diagnosis for those who have the fear of hepatitis C virus infection, whether you have thought you have acquired it because you were in contact with someone who had hepatitis C virus, or because of the nature of your job, or because of lifestyle, or you don't even know how you could be screened. And to those in the medical profession, maybe you don't know yet who should be screened and how to make a definitive diagnosis of hepatitis C virus. I have the answers for you today as per the screening and diagnosis of hepatitis C virus. I have already published a different presentation on hepatitis C virus where I have explained the symptoms, the historical part and progression to chronic hepatitis C virus, from acute hepatitis C virus and to fibrosis and to liver failure. You can check my channel for that. Today is all about screening and diagnosis. Who should be screened? All adults ages 18 to 79 should be screened for hepatitis C. We should screen all IV drug users. Anyone with abnormal liver function test without the definitive cause should have screening done. Babies delivered to mothers with hepatitis C virus should have screening done. Healthcare providers, emergency or rescue workers should all be screened for hepatitis C. Still on those who should be screened, people on long-term hemodialysis should have screening done. Anyone who had received blood transfusion before 1992 should have hepatitis C screening done right now. Sexual partners of anyone already diagnosed with hepatitis C virus infection should be screened today. All HIV patients, all prison inmates, and everyone born between 1945 and 1965 should be screened for hepatitis C virus. The diagnosis. The long journey to definitive diagnosis of hepatitis C virus will start with a thorough history. History of the year of birth, the age, any past blood transfusion, particularly before 1992. Are you on hemodialysis for a long period of time? How about lifestyle like IV drug usage and any concomitant infection with hepatitis B or HIV? Now, we ask all this history and, of course, history of symptoms, and we'll look out for the signs on thorough physical examination. After we've gone through this, then we'll head into the lab. Going to the lab to do what? To determine the viral load, to do hepatitis C virus genotype. And why that? Because when we know the hepatitis C virus genotype, we'll be able to pick appropriate antiviral agent and embark on the appropriate pattern of treatment that will be helpful to the affected individual. We will have clotting provider because all clotting factors, except two, are produced in the liver. And now the liver is under insult. The two clotting factors that are not produced in the liver are just factor 8 and von Willebrand factor. The rest, either the extrinsic pathway or intrinsic pathway, are all produced in the liver. Then we have albumin. Remember, it means we are dealing with liver function tests already. And of course, we do liver enzymes as well. So we know the level of albumin. We know the level of glucose, and why that? Remember, the liver has the capability of glycogen storage. And we have to know what alpha-1 antitrypsin is all about. Those with emphysema will know how important this is. Bilirubin level will be assayed because we'll be dealing with probable hyperbilirubinemia, but this time around it's going to be conjugated. HIV screening, because it's going to be a different prognosis entirely when there is concomitant hepatitis C virus with HIV. But we're not done yet. We want to know if this patient who may be having hepatitis C or who has already been diagnosed with hepatitis C could or has already not been infected with hepatitis B, hepatitis A, hepatitis D on top of hepatitis B, or hepatitis E. We are not done yet. We want to know what complete blood count is, and of course the level of the platelets, because low platelets will lead to bleeding. And we have to get our people in microbiology to help out with blood culture in case of spontaneous bacterial peritonitis. We will have urinalysis and of course renal function tests done by knowing blood urea nitrogen and creatinine level. And we have to know rheumatoid factor level as well. We will then be able to come down on hepatitis C. After doing all those things, then we'll do ultrasound first, and we can then have liver biopsy. In some big centers, you can have magnetic resonance elastography. Okay, there's a picture here of what we may likely get after we've done everything. We've done the laboratory work, ultrasound, and liver biopsy, and so on. 1/3 will likely have normal ALT. 2/3 will have slightly raised ALT. But liver histology and ALT level will share no correlation when it comes to diagnosis of hepatitis C virus. Let me explain. The fact that ALT is normal is not predictive that histopathological results will be normal, or the fact that ALT is raised is not predictive that histopathological reports will indicate infection. Viral load is relatively constant. Hepatitis C virus levels will increase in the phase of HIV infection. That is why we always screen for HIV infection in anyone that hepatitis C virus is suspected. There will be a drop in hepatitis C virus RNA in the face of acute hepatitis B virus infection. There will be increase of faster fibrosis when there is co-infection of hepatitis C virus with HIV or hepatitis B virus. Let me explain. When an individual with hepatitis C virus is diagnosed with HIV virus at the same time, or is diagnosed with hepatitis B virus at the same time, then there will be a horrible degeneration of the liver into fibrosis. Okay, there is likelihood of decreased platelets in immune thrombocytopenic purpura, on account of which the individual will be bleeding. Rheumatoid factor will likely become reactive, and of course, we'll be dealing with proteinuria, hematuria, or glomerulonephritis. And that is why we will do urinalysis. And that is why we will have blood urea nitrogen and creatinine done. And when all these are picked, then we will know how to focus on the treatment. So if you have the fear that maybe you have acquired hepatitis C virus, you don't have symptoms and you don't have signs yet, don't worry. Just walk to your doctor and go through the list of who should be screened. Like if you're a health care provider and you've never been screened but you have the fear, just have the screening done. Or someone around you already been diagnosed with hepatitis C virus, or your partner, you need to be screened. Or the year you were born, or you're on long-time hemodialysis, or you have blood transfusion before 1992. Just go over that list and get this gamut of investigations done so that you have peace of mind. And when the genotype of hepatitis C virus has been determined, don't worry. Very soon I'll publish a whole list of how we can handle hepatitis C virus as per the treatment. With that, I've come to the end of this very presentation. Remember to share, remember to subscribe. And in the next few days, I'll be publishing more on hepatitis C virus. Check my channel for hepatitis A, hepatitis B, already published. I appreciate it. Remember to share, remember to subscribe. Thank you.